This is going to be a three-part presentation. I'm the first of the speakers, and it's going to be from research to practice. My talk is going to be sad experience, how to set up a program, how not to do it. Now, this is from the point of view in an academic institution, not a private practice, so we may have a little different problems. Is it possible to turn down the lights a little bit? I have no important disclosures. Since I'm the first speaker, I'm going to give a little bit of background on lung cancer screening, why we're talking about it today, and then how to start this program and our experiences. As you all know, lung cancer screening is the leading cause of cancer death in the United States, more so than these four very prevalent cancers put together. It's predominantly a male problem, but since smoking is now more prevalent among females, they're starting to catch up. We also know that there's a fair number of non-smoking related cancers, especially in females. This is the kind of mortality table that we're all used to seeing for different cancers, and we know that the earlier we pick up a cancer, especially lung cancer in stage 1A or 1B, the better the 5-year prognosis. The problem has been picking up those cancers, and that's what we're here to talk about. So if we look at this pie chart, if we try to pick up patients in 1A or 1B, we see that the survival is pretty decent. But as you work your way down, it drops to about 10%. And unfortunately, at least half the patients we pick up in daily practice are in this stage 4 category. And there are things that could be done for the patients, but the chance of 5-year survival are really pretty slim. So when we talk about successful screening, we talk about it has to be a disease that's frequent in the population. There's got to be a reasonable method of early detection. Early treatment has to lead to some benefit. Those benefits have to be counterbalanced against the harms of treatment or diagnosis, and the cost has to be within some reasonable bounds. In the 1970s and 80s, there were various studies using chest x-rays. It made sense. If you could pick up a lung cancer earlier on a chest x-ray, that would be beneficial and quite inexpensive. Unfortunately, most of those large studies, including this one from Mayo, showed that if you looked at the 5-year survival, there really wasn't any benefit to doing chest x-rays. So that kind of dropped off the radar, and we weren't doing any screening for lung cancer. Then CT came along, and it became obvious to all of us that CT could pick up cancers that we weren't picking up on the chest x-ray. So that one was easy. And how many of you saw that one? I certainly didn't. So maybe this works. Maybe this is better than chest x-rays, and maybe we'll actually accomplish something. So under the direction of Claudia Henschke in New York, she put together LCAP, which is the Early Lung Cancer Action Project, which was the first comprehensive look at CT for lung cancer screening. And in her first 1,000 patients, she found 23% had pulmonary nodules. Most of them were small, but only a very small percentage of them actually turned out to be lung cancer. So you had all of these false positives, worried patients, extra expense, extra workup for picking up 2 malignancies out of 100. And most of them were stage 1, just as you would hope. And the patients did better. Problem is she had no controls, and there was a lot of objection to this. And her controls were just historic data from what we knew, taking care of patients. So with the help of the FACR and lots of other groups, the National Lung Cancer Screening Trial came in, looking at 26,000 patients who got CTs, an equal number who got x-rays. And as you would expect, you found more nodules on CT. Again, Again, most of them were false positives. In other words, they were nodules, but they didn't turn out to be cancer, and we didn't benefit much from knowing that they were there. But the important thing is the next to the last thing on this chart, lung cancer mortality went down 20%. And that's better than many other screening studies at a cost that was comparable to things like mammography or colonoscopy, if anything, a little bit less. And overall mortality went down 6%. And if we look at this Danish study, we see that we went from 30% early stage lung cancer to 70% early stage lung cancer in the screeners. So there's lots of data out there that suggests that this is going to work. So now let's talk a little bit about lung cancer screening. If you're looking to set up a program, you have to think mammography. You're not just reading CT scans. That's the easiest part of the whole project. The hard part is putting together a team. So, as radiologists, we look at it this way, but this is really the way we have to look at it. This is a team effort throughout the whole hospital. And when we first started 4 or 5 years ago, we tried to make it a team effort with no reimbursement. And that was not real popular. So things have changed. It's now reimbursed, and the milieu is different. And this team has to be from the hospital administration all the way down to all those folks, physicians who treat lung cancer. Then you need all that statistical administrative backup. And the ideal way is to have it come from the top down. Have your administrator come pound on your desk and say, we have to do this, and here's the money to do it. How many have had that experience? Okay. This is how we started, from the bottom up. Dave Johnstone and I went to administration, and after 6 months of frustration, they said, well, there's no reimbursement. You know, we're not interested. Then we went to pulmonary medicine, and they said, we're too busy. We already have too many patients. We don't need all your nodules. Internal medicine was skeptical. They had gotten burned with PSAs for prostate, and they didn't need one more test that they had to explain to their patients why it wasn't any good 5 years later. So they weren't really happy. So we were left trying to do it ourselves, and we just decided we were going to do it ourselves. And we put together a very small team, meaning myself and one nurse practitioner, and that was the team. And then we farmed out patients as we saw, as the need came up. And eventually, now that it's being reimbursed, all of a sudden people higher in the chain are being a little more interested. So we're getting a little more cooperation now, and we're in the midst of getting together with pulmonary medicine and moving administration of this program from us to pulmonary medicine, where I think it should have been from the beginning. Radiology has to have a big team just within the team, the radiologists. You really should have ACR recognition, and I'll show you in a minute. You need your CT team. You know, you have to have enough capacity in your system to scan patients. Protocols are relatively easy to set up. You need some type of patient navigator, or nurse practitioner, or nurse, someone who can really dedicate his or her time to taking care of the patients, getting them enrolled, getting them to understand what it's about, getting them involved in smoking cessation, et cetera, et cetera. Your scheduling desk, your billing office, Epic is a challenge for those of you who work with Epic. We put together report templates. We went to our data center. They put together all the data for us for 2 years. And last month they told me that the whole system doesn't work, and we're going to have to start from scratch. So there are things that go on. And then you have to upload your data to a national database. We'll talk about this. This is the ACR recognition for lung cancer screening. And the reason I put this up first, it kind of defines what the parameters are that you really should be paying attention to. Your patient population, smoking cessation, radiologists have to meet a certain criteria. It's not hard, 200 chest CTs in 36 months. Structured reporting, you need a high-end CT scanner. You just need a CT scanner that can give you 2.5 millimeter slices. 1.25 is better. Iterative reconstruction is better because you really have to do it as low dose, etc. So, patient intake, schedule desk, patient navigator. At our place, our patient navigator talks to the patient. Before they have their scan, patient is asked if they want their results. Immediately, we wet read them. They're relatively quick reads, at least as a first pass. And then she talks to them before they go home. I think this is the ideal way to do it. I think it's not practical in many situations. So if you're interested in this, you'll have to figure out some kind of mechanism that works for you. This is our intake form. Get basic data. The ACR requires some of this basic data. You don't have to look at all this. We don't have time, but I think you can kind of figure out what you need to put together. The CT protocol, it's a low-dose protocol, thin sections. We use a fixed KV of 120 and a variable MA based on weight. And as you get into bigger patients, some of the images are noisy, especially up at the across the shoulders. But you can learn to live with that. I'll show you an example or two. Iterative reconstruction, of course, knocks down the dose by another 30%. And having axials, coronals, and sagittal images really help. Because sometimes something looks like a nodule in the axial, and you look at the coronal, it's a lymph node, it's a flat scar, it's something. So I think that's really important. And it's mandated that you keep your CTDI to less than 3 milligray, which I think most of us should be able to do. So the top set of slides is a full dose CT. The bottom set is a reduced dose CT using iterative reconstruction. And you can see it's a little noisier. But in the lung, the noise isn't so bothersome. It's mainly in the mediastinum, and we're not doing this for the mediastinum. And truthfully, even though it's noisy, you can usually pull out what you need. This isn't about looking for lymphoma or a new lymph node in a lung cancer recurrence. So these are the values from those two patients. And you can see using the low dose technique, we've cut the dose to less than a millisievert from 7 millisieverts. And we're seeing this in a lot of the patients. The iterative reconstruction certainly helps. So here's an example of one of our pickups. We have picked up several lung cancers. And this is a 7 millimeter spiculated nodule. You see that the image is a little bit noisy, but certainly usable. I think most of us would be happy to read this. I put together a template that we just go bing, 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 and we work our way down. And we only fill in the positives. So for example, if there were lung findings other than a pulmonary nodule, we would go to that drop-down menu, which would be COPD, fibrosis, lymph node, et cetera, and we just fill that in. So that works quickly, because if you're doing a screening test, it's got to be relatively quick and efficient. This is lung RADS, which you've heard so much about. It's almost impossible to read. Everything printed is this small. And I actually have to take out my glasses and turn on the light and read the damn thing. So I put together lung RADS Lite. So it's at least a place to start. And it's like breast RADS, and it's not so difficult. I mean, you're not going to memorize everything, because you have a 6 millimeter ground glass nodule. You just look down the chart and you figure out where that goes. It's just not that big a deal. And lung RADS is different than that NLST, National Lung Cancer Screening definition. It's also different than Fleischner. We're not going to get into why it's different from Fleischner, but you have to be careful. It's not the same rules, because this assumes that the patient's going to come back in 1 year and have a second screening. Fleischner doesn't assume that that's going to happen. So what lung RADS said was we have too many false positives. 23%, 25% is just too many. What would happen if we use 6 millimeters as a definition of a positive nodule rather than 4 millimeters for definition of a positive nodule? And they went, in this particular study, looking back at NLST, they went from 27% positive rate to 10%. Well, that means now only 10% of your patients fall into some category that requires further imaging or something more. So that's a lot more acceptable. And in this group of 152 patients, not one lung cancer was kind of overlooked in that interval. So it seems to work, and your positive predictive value more than doubled. So NLST is what most of us are using now, and this is what CMS wants us to use. So I think that's been a big step forward. Then you have to track all the data. This is from my database, which doesn't work anymore. But we keep all of that information on the patients, because eventually we're going to want to look at how we're doing, do some quality control. Then you go to the registry. The ACR put together a registry that CMS has said is acceptable so they can track quality. And I think the people who put this together were the same people who did the website for Obamacare. You know, they were unemployed and the ACR probably got them at a good price. Hope no one was on that committee. Were you on that committee, Stacey? Okay. Anyway, it's still a work in progress, folks. This whole thing has been a work in progress. Every 6 months, the rules changed as we try to get this up and running. So you have several forms that you have to fill out. This is the patient registry form that gives you all the background information, age, sex, smoking history, et cetera, et cetera. Then you have this short form for filling out the results of your test. Now, most of it you don't even have to fill out because most of the patients don't have those things. So it's just checkbox, checkbox. But you either have to do this individually for each patient, or if you have a successful database that matches that ACR website, you can just batch upload it. We haven't been successful, and we're actually putting each patient in individually. Eric, about how long does it take for a... Yeah. 5 minutes. It's a long form, but you get quick at that. We've also decided because we have top-notch equipment, we can see the coronaries in these patients. So we actually give a coronary screening score, which has been proven in several studies to be within 10% of an Agatston score, even though this is not gated. So this is now part of our routine. And as part of making lung cancer screening more than just lung cancer screening, if you could make it cardiopulmonary health screening, you're adding a lot more value per dollar that you're spending. So you get cardiac score. We are looking at a software package to give an emphysema score. And the clinicians think that this is going to be helpful in explaining to their patients what emphysema really is and why they might want to stop smoking. We haven't instituted this yet. The hospital team are all these folks, and I don't have time to go through all of them. Just going to highlight a few things that I think are important. First thing is winning over the clinicians who are going to be sending you the patients. It's mainly primary care and the internists. And as I said, a lot of them are skeptical. They have 15 minutes with a patient. The patient came to them for a bellyache, and now they have to take 5 minutes to explain lung cancer screening to them. So a lot of them are reluctant to get involved. Some of them have really sent a lot of patients, others haven't sent any. And we've gone around to the various clinics to talk to their monthly staff meeting and stuff. And some like the idea and some don't. But I think as time goes on and they see that the program works, we're getting more and more referrals from some of the reluctant docs. You have to have an easy ordering system on Epic or whatever your computerized ordering system is, because CMS requires a lot of data as far as smoking history, years since quitting if they quit. Your physician has to attest that he's done patient shared decision making. And this is one of the sticking points. They have to discuss with the patient all kinds of different things, which we'll see in a minute, which takes their time. I don't think they object to what we're saying, but time is of the essence. Your reports have to be clear to the physicians, spell it out. If I find a suspicious nodule, I call. And then the next problem is the patient's supposed to come back at 1 year and 2 years if they have nothing suspicious. So you have to figure out a routine for getting them back. Or if, let's say, you see a 7 millimeter nodule that requires a 3-month follow-up, just like mammography, you have to make sure those patients don't get lost to the system. And this is hard for a radiologist to do. So this is our Epic screen. I'm not sure you can read it, but basically it attests to how much they smoked, did they quit smoking, did you do your shared decision making, has the patient had a pneumonia in the last 3 months? You don't want to CT those folks till things clear up. Have the patients had a chest CT someplace else in the hospital in the last year? So there are some other minor things you have to go through. And shared decision making, these are the things that the internist is supposed to discuss with the patient. The benefits, the harms, the relative radiation exposure, the need to adhere to a 3-year schedule, what do comorbidities mean? If you have bad heart failure and bad COPD, you're not going to benefit from lung cancer screening because there's not going to be much in the way of therapy. So this is what the internist is required to swear to on that sheet. So, as I said, I think we should move to think about this cardiopulmonary health. Low-dose CT, smoking cessation is a requirement from CMS, and I think that's correct. We'll talk about that in a minute. And we have different clinics to refer the patients to. Now, we all know these are some of my heroes from when I was growing up, and apparently they were wrong. How do we get people off smoking? Half our patients are still smoking, half aren't. The ones that are still smoking want to continue smoking. Most of the men, anyway, are there because their wives get pestering them to get this damn CT test. The women seem to come in voluntarily. But most of them don't want to stop smoking. That's our experience. We do offer all these different options for them, but our success rate is relatively low. I was never sure that it would work. If you've already been smoking 50 pack years, does it make sense to stop? But here's some data that shows the further you are from smoking, the less your relative risk of lung cancer. So by quitting 10 years or more, you cut your risk by 50%. So there's really value in smoking cessation. It's better for heart disease, it's better for lung disease, it's better for cancer. But you really have to work hard at getting the patients into this, because most of them don't want to quit. This is the extreme I found on the internet. I mean, but it hasn't been very successful. Some of the patients are difficult to follow up. They're not in your system. The internist is busy. The internists think it's like mammography, that mammography is going to take care of everything related to that problem, and they're not tuned into the fact that they have to be part of this project. We involved our public relations department. They put together a very nice brochure, several smiling couples. Everything looks good. We're also up on the Freighted website under lung cancer screening. So I don't know how successful that has been, but we have all those things in place. Take the last few minutes to talk about the future. I think the guidelines are going to change over the next few years. They're going to be refined. Right now, CMS recognizes this group 1 group, 50 to 75 years of age, et cetera, 30 pack years. There's a second high-risk group that's not included in the CMS guidelines. A little younger patient, a little less smoking history, but all of those other cancer-related factors, family history, occupational history, et cetera. And they don't qualify under CMS for Medicare reimbursement. So you can do them under private insurance, or if your hospital is going to subsidize these folks, but Medicare won't recognize that. And in this study, they looked at group 2 versus group 1. The overall incidence of malignancy was exactly the same. The average follow-up was the same. The annualized malignancy rate was the same. And the stage at pickup was very similar. So there's a whole group out there, a smaller group, that really deserve screening, but don't qualify at this point. And here you can see that still the majority are smoking, and then there's other occupational diseases. This just came out last month. Don't bother to read it. Basically what it said was, if your first screen is negative, the chance of you being positive on the second screen is extremely low. Maybe we shouldn't require those people with negative first screens to come back at 1 year. Maybe they should come back at 2 years. So I think this is the way these guidelines are going to morph over the next 5 or 10 years. We're going to break down the patients to a little wiser way of following them up. Next thing is better computer help. CAD is there, it's available on some systems. Volume is better than linear measurements, but this isn't recognized right now in lung reds. All throughout Europe, all of the European trials are using volume. I think that's much better than we're doing, because we all know what it means to measure a 6 millimeter ground glass nodule. It's tough. People are working on texture analysis, looking at the actual texture of the nodules to perhaps give us a little better understanding of which nodules to worry about and which ones not to. So here's a patient done 3 different times. The linear measurements and the volume measurements. And the volume measurements are, I think, much more reliable and reproducible. And there's a lot less intra-observer error. We all know that if you measure that nodule and I measure that 6 millimeter nodule, we're going to come up with slightly different numbers, whereas the computer does a better job. And the last thing I'm going to talk about is biomarkers, which are a fancy term for any test that tells you something about the patient's risk. And right now we use history, but I think there are going to be blood tests out there, sputum tests, genetic tests, exhaled gas tests that are going to say you need lung cancer screening and you don't need lung cancer screening. Because right now we're just picking up 1 out of 100 patients, and that's crazy. So I'm going to end by this. One of the biomarkers that's being looked at in Israel is trained dogs. Dogs can sniff out lung cancer and breast cancer with about 80% sensitivity. So I think in the future, we're going to do a dog scan, a cat scan, and a pet scan, and we'll be done. So, to conclude, 3 months ago, the FACR had a whole supplement on lung cancer screening. And for those of you who are in smaller hospitals, there was a terrific article called Implementing Community Lung Cancer at a hospital in Elkhart, Indiana. And they went through all those steps. And I think that's an excellent place to start.